It is 8 o'clock, and I'd like to start introducing this because there's a lot of information in this topic. Um, I think most people y'all know me. I'm Patty Gibson, and the director of medical director for behavioral health at Arkansas Blue Cross Blue Shield now, but also a co-founder of Arkansas Behavioral Health Integration Network, ABIN. Our CEO, Kim Schuler, happens to be off in a wonderful PTO in Italy right now. And so we're all jealous, but she's kept us in good hands so that we can keep moving along. I'm really excited that ABIN is able to continue to provide monthly webinars free, and they are on a website and recordings. And I find myself frequently going there to get some information for various topics related to behavioral health and behavioral health integration. And we get some really wonderful national speakers because one of the principles for ABIN is we want to bring national evidence-based, research-based information to the state of Arkansas. We do not have to figure out everything on our own, that we can use national standards. And I'm happy to say there is a lot of that happening. One of the reasons that I am now working on the dark side, that I'm working for the payer, Arkansas Blue Cross Blue Shield. No one goes to medical school thinking that they are going to go work for the insurance company for the man. And I know that there is a lot of publicity now about frustrations between patients, clinicians, facilities, and insurance payers. And I just want you to know everybody is not bad, that actually a lot of the people who work for the payer side, we are trying to make sure that our patients get care and get good quality care. And we want to make that happen. And so that Arkansas Blue Cross continues to support me being involved with all of our clinicians and with ABIN and with integrated behavioral health. So I'm very happy to be able to be here and be part of this webinar. So as I mentioned, we frequently have national speakers, and we're very blessed to have a very high quality speaker today. Kim Hahn is actually from Arkansas and is employed at Arkansas Blue Cross Blue Shield as her official title is in Risk Adjustment Education, Provider Engagement Specialist and Coder. And as I was just mentioning to her, those of us who are clinicians, we don't get training in coding and billing. We hardly even know what to write on the chart for what the diagnosis is because we're so focused on the clinical part of what's the diagnosis, what's the treatment. But as times are changing, we need to get ourselves more educated, not just our billing teams, but ourselves to understand, because that's in the best interest of our patients and of our own practices. Because when we're providing clinical care, we have to be able to survive and be economically viable. And so this is really important. And that's why Blue Cross wants to lead the way to make sure that billing and getting paid is not a hard thing to do. So we have resources available, and Kim Hahn is one of them. We also, Arkansas Blue Cross likes to work with all the other payers in the state and nationally. So I know that they have a lot of the same attitudes, priorities, and approaches to getting care paid for our patients. So with nothing else for me to say, I want to introduce Kim Hahn, CPC, CDEO, CRC. And that means she's a certified professional coder, certified professional coder in outpatient and in risk adjustment. And she'll say more about that. But I have heard this talk a couple of times, and she continues to improve it and evolve it. She will be taking questions after her presentation, so feel free to put questions in the chat. Kim has a clinical background working in the medical field for more than 23 years before she started focusing on medical coding. Being involved at Arkansas Blue Cross and on the ACA risk adjustment team, her role is a risk coder and a provider engagement specialist working with healthcare providers on documentation and coding compliance with current ICD-10, CPT, and the CMS guidelines. And so you'll hear her talking a lot about this is what CMS wants, this is what Arkansas Blue Cross wants, this is what other payers want as well. So Kim, I'll turn it over to you, and thank you so much for being here, and thank you for everybody who's attending in the audience. Once again, if you'll put your name, your organization, your role, and any questions you have in the chat, we'll get those at the end of the presentation. Thank you.
Well, hello and good morning. Thank you for having me. So this morning, like she mentioned, I will cover what is required when it comes to reporting diagnoses on claims for each patient encounter, each patient visit. I'll explain as well what risk adjustment has to do with it. We get a lot of questions on that. And if you've heard a previous presentation of mine, I have webinars ongoing right now. This is the presentation. You'll be familiar with this. And like she mentioned, I am happy to answer questions at the end. So let's go ahead and get started. And first, our disclaimer. So this presentation is based on current guidelines. However, guidelines are updated each year, and when changes happen, current guidelines should then be followed. CMS has order in which resources should be followed. ICD-10 and then AHA Coding Clinic for diagnosis codes, and CPT for your E&M procedure service codes. And this is something we all comply with. These are the resources for today's material. And then finally, no part of this presentation may be copied, recorded, or reused without our consent. That said, we have given consent, like Dr. Gibson mentioned, for this to be recorded today and posted by your organization. Please just, keep in mind, there are constant changes, CMS updates October 1st. The 2026 updates go into effect, and there are hundreds of changes here to support more precise documentation and code reporting of patient condition. There will be 487. Now this is ICD-10. So there are 487 new diagnosis codes, 28 deleted and 38 revised, in addition to changes to their official guidelines. So these 2026 updates are not included in this information. And afterward, if you need me to share, this is all on the CMS website. You can download it. I downloaded some new things this morning, so I'm happy to share that as well. Okay, but the new updates are not included in this information today. So let's start with risk adjustment. So risk adjustment comes down to documentation and diagnoses that you report on your claims, providing CMS with data needed to understand the patient's clinical situation, as well as understand what it will cost to care for that patient. But most importantly, they are trying to see the full clinical picture of your patient for each visit, for each encounter. And in your practice, many of your patients have chronic or other ongoing conditions that affect your patient's mental or behavioral health condition. Chronic conditions like, diabetes, COPD, autoimmune diseases, cancers, leukemia. So patients may, your patients may have more than one or, behavioral health condition as well as these ongoing chronic conditions. So CMS appreciates your patients can be complex and your care can be complex as well. So each claim you submit tells that patient's story, giving CMS the data needed, and we'll break that down. So it all starts with your documentation, and I cannot express the importance of precise documentation enough. So please do think precision, and remember, precision doesn't mean lengthy, just to the point and accurate. And accurate documentation means more specific codes are supported and sent in on claims, providing more accurate data by painting that clinical picture of your patient, which in turn supports treatment and services you provide, along with improving continuity of care. And then diagnosis codes. So diagnosis codes are to come directly from your documentation. CMS wants the clinical picture of your patient through diagnosis codes. So like you see here, diagnosis codes tell more than just a diagnosis. Diagnosis codes assign weight that measure acuity. Diagnosis codes describe the intensity and severity of the disease or illness. Diagnosis codes explain the use of resources. Diagnosis codes support your E&M levels, your time spent with your patient. So diagnosis codes are tied to quality, cost, and outcome data. Data to CMS through diagnosis codes you submit on your claims, submitting and reporting the true clinical picture. And again, it supports and reflects your care, treatment, and recommendations. And this in turn reflects what it will cost to care for that patient. Okay, so this is a reminder that inpatient and outpatient documentation is sometimes treated differently in the coding and reporting world of coding guidelines. And one example is when a diagnosis is suspected, not yet confirmed. In the inpatient setting, you can report the code for what is suspected probable as confirmed. It's appreciated that in the inpatient setting, the healthcare provider, you're treating the condition the same, and the diagnosis will be confirmed during process of treatment and testing in that setting. However, you can only code, report on your claims to the highest level of certainty. So in the outpatient setting, guidelines here tell us to code or report signs and symptoms with documentation stating what you suspect, which will support, treatment and testing. So if you suspect bipolar disorder in the inpatient setting, you can report the code for bipolar disorder. In the outpatient setting, report the code for what you're certain of, maybe depression or mania, until you confirm or rule out bipolar disorder. That said, once the diagnosis is confirmed, please then report the confirmed diagnosis, the complete current diagnosis. And this is very important, and you'll hear me say multiple times as well. Each date of service must stand alone. So documentation and codes reported for each visit stand alone. CMS does not accept a diagnosis or specificity from one date of service to apply for any other date of service. And all elements must be present to represent an encounter. Just remember, each visit documentation must support all diagnoses you submit on claims and tell the clinical picture of that patient for that visit. And then this last bullet, it is very important to continue to document a diagnosis presence, even if symptoms are well controlled to the point of not being detected due to treatment. Again, this best supports your quality care, your treatment plan, as well as the patient's compliance. And when conditions are asymptomatic, they are often not mentioned in your documentation, and diagnoses are not submitted on claims. So please don't forget to report, document and report these asymptomatic conditions, so continued treatment or surveillance is supported. Okay, a little more on risk adjustment. Well, like I've been mentioning, CMS is all about the data and getting it right. So data to CMS through diagnosis codes. And this data is how CMS calculates expected cost for that patient. CMS has created hierarchical condition categories, or HCC models. There's a model for all lines of business. There's one for commercial, Medicare, Medicaid, models that best fit the patients that are enrolled in those plans. And each model has hierarchical codes, again, that are selected by CMS that have different risk adjustment associated with them. And there's an overall risk adjustment factor score, or RAF score, for the patient. The patient's RAF score is calculated by the patient's demographics, including their age and gender, added to diagnoses you report on your claims. So patient demographics, who they are, plus your diagnoses equal the patient's risk factor score. This risk score should also coincide with services you provide and treatment you recommend for those conditions. Okay, getting back to specifics, like I touched on in the beginning, please also document and code all chronic conditions that may affect or contribute to your patient's behavioral health condition, or that may affect treatment of those conditions. Chronic conditions like you see listed here, heart disease, cirrhosis. It is appropriate to document these conditions that contribute to or affect treatment, even if you're not the treating provider of those conditions. So if your patient has bipolar disorder, most recent episode depressed severe, and the patient also has systemic lupus or cancer, for example, you report the cancer or lupus with bipolar disorder because those conditions will contribute to bipolar depression and affect what treatment options you have. A new cancer diagnosis would likely, have a huge impact and create several changes to treatment. Maybe now you need to increase or decrease something. The additional diagnosis would support those changes. Also, it factors into your medical decision making. If you have to think about it, please document it and report it on your claims. You are aware of these conditions that are affecting your patient, and just because the other provider is reporting that condition, CMS does not consider it when looking at your documentation or looking at your claims unless you document it and report it. Again, it goes back to each data service, each encounter must stand alone. They are only looking at the data you present for that encounter to support, your medical decision making, your treatment plan, and understand the true clinical picture and predict, the cost. It also improves continuity of care. Okay, this is a common misunderstanding of wording and documentation, and if you've heard me, you've certainly heard this. It has been, and for some still is, common practice to state this patient has a history of what is usually a chronic ongoing condition. However, stating history of any condition in your documentation tells CMS this condition no longer exists. So it is important, if the condition does exist, that you report it as an active or ongoing condition in whatever stage it may exist in, including remission. And if you have history of in documentation and then send in the code for the active condition, this is conflicting and CMS will deny that diagnosis. So documentation that you thought was supporting a diagnosis could actually be conflicting. And if you list a diagnosis in the past medical history list and do not again have it in your assessment, this leaves the condition in past medical history, which also means history of or no longer exist. So please instead document and report the complete current status, like you see here. Patient has known bipolar disorder, and then follow up with specifics, bipolar disorder in partial remission, most recent episode depressed. Maybe stating current conditions include generalized anxiety controlled with Celexa, as well as exercising situational coping skills. Patient has alcohol dependence in sustained remission. Patient's current conditions also include ADHD, predominantly inattentive, doing well on Vyvanse. So you can see how the difference in what is being, said, what is being told about the patient's current condition. This is an area where small changes in your documentation can make a really big difference. By supporting the specificity and reporting the specificity, even linking, to medication and treatment, that can be done in just a sentence or two. So this is what we would love to see in your assessment and plan. And you can see how documenting and reporting the complete current status of a diagnosis, how that paints a very different clinical picture than just history of. And please always keep in mind, your assessment and plan will reconcile all other documentation. It is appreciated as that. It is your final say, your final assessment and plan. Okay, so here we have the elements of documentation for a visit. So the visit should include, we'll begin with the chief complaint or why the patient is here, history of present illness or factors of the patient's present condition. If this is a follow-up visit, what changes of condition or to treatment have been made, and how has the patient responded to that treatment? Was the patient compliant with your treatment plan, etc.? And then next, the past medical family social history. So these are the patient's chronic conditions that may be contributing to their mental or behavioral health condition. Also, any family or social history or stressors or factors like homelessness, family stressors, things that may be contributing. And I will say here, please also remember when you're documenting these, like we just covered, make sure to use present tense instead of past tense for all conditions and factors that are still present. So if the patient has a history of sexual abuse or history of trauma, that is stated and coded as history of. However, if the patient currently has family or job stressors that are current or current psychosis, please document those as current and document what they're due to, like for psychosis, maybe methamphetamine abuse or bipolar mixed severe with psychosis. So document the summary with treatment plan, the assessment and plan like we just discussed on the previous slide, linking all treatment to the condition or conditions that it may, that it's treating. So also remember to include all other diagnoses, those chronic conditions, COPD, cirrhosis, things that are contributing factors, even when you are not the treating provider of those conditions. Please always link the diagnosis to the treatment plan to include all diagnoses a medication is treating. I understand that, certain medications can treat more than one diagnosis. Therapy, of course, and so on, can treat more than one diagnosis. And another thing is your past medical, family, social history. This may not change visit after visit, but please have a plan for when you do update this information and date it. If you have a documentation template that has a list of the past, medical, family, social history, has that listed and then different dates of service listed below that, visit after visit after visit. Please remember that only the documentation under that date of service, this is the only documentation that can be considered for that encounter. So just be careful and, understand that. Just be careful that the documentation is sufficient to support what you are reporting on claims. And when you're documenting substance use, abuse, or dependence, there is a hierarchy. And as we all understand, dependence is the hierarchy. But if you have in your documentation abuse and dependence, for example, then we would understand you to report the code for dependence, dependence being the hierarchy. Also be careful when you're documenting and using these words interchangeably. Just be careful to ensure proper coding and reporting. Be consistent and not waver back and forth, because that can be a red flag. Okay, looking at a few substance use disorders. We see here alcohol-related, cannabis, opioid, stimulant-related, hallucinogen, inhalant. All except nicotine are coded as use, abuse, or dependence, and either uncomplicated, with intoxication, intoxication, delirium, withdrawal, psychotic disorder, other induced disorder. So we need to know from you which is present for the encounter. So please do specify. If you report uncomplicated and then order an antipsychotic drug, for example, then that's a question, a red flag. So the specific diagnosis to include with psychosis if present and treating the psychosis, that tells the true clinical picture of what is current, and it supports your treatment. Also be aware that reporting a code for stimulant abuse unspecified and then reporting F29 for unspecified psychosis not due to a substance or known physiological condition, here you're saying the psychosis is not related. So always remember, when you report separately, you're saying they're not related. And if they are related, report that combination code or explain in your documentation. So, there is support and there's, not confusion, not a red flag. And we'll talk about that a little more in a minute. Okay, so DSM-5 and ICD-10. So ICD-10 has picked up guidance from DSM-5, and it appreciates that substance withdrawal can occur in clinical situations where the individual is physiologically addicted to a substance without having the behavioral elements required for a diagnosis of dependence, like when a patient is taking medication as prescribed, but can experience withdrawal when the medication is stopped. Or a patient can experience withdrawal in substance abuse when they lack the loss of control required for dependence. So it is appreciated that withdrawal is not synonymous with dependence, and there are codes, to be specific, abuse or dependence, withdrawal in use as well as independence. Okay, in 2023, ICD-10 included codes or added codes for use in remission. So here, remembering our hierarchy for substance use, abuse, or dependence, if it is known your patient is in remission, yet not known whether it's abuse or dependence, we now have a code for use in remission. Just remember, when you know, it is best to be consistent and documenting and coding the accurate current state. And these are codes to, help you be more precise. Okay, now moving on to schizophrenia, please specify if it's paranoid, disorganized, catatonic, undifferentiated, residual, or other. There is a code for unspecified. However, if it's known, it is important to document it and report what is known, what is current. Again, this best represents the true clinical picture, and it best supports your treatment and recommendations. And also, like I know you're aware of, but it is important to include in your documentation whether or not the patient is compliant with your treatment plan, and if your treatment plan is effective. It supports any changes you make. Okay, moving on down to other codes that can be, problematic, F28 and F29. So F28 for other psychotic disorder, not due to a substance or known physiological condition. Just remember here, when you use the code for other, please specify what the other is, like chronic hallucinatory psychosis, for example. That's listed in the book, like you see here under F28. There's not a specific code for that. So anytime you're reporting other, this is an ICD-10 coding guideline. Anytime you report the code for other, you must state what that other is in your documentation. And then F29, unspecified psychosis, not due to a substance or known physiological condition. Here, I think, F29 is commonly reported as a default code. However, F29 should only be used, and this comes from DSM-5, should only be used when the criteria are not met for a specific schizophrenia spectrum disorder, or there isn't sufficient information to make a more specific diagnosis, or is related to a substance. So if this is your initial diagnosis, please update it as soon as you know in your documentation and report that specified diagnosis on your claims. This is a common issue for many. F29 is commonly reported visit after visit without being updated. So if you say the patient has unspecified psychosis and the patient has a known cause, like schizoaffective, bipolar disorder, manic type, please link the psychosis when they are related. Please only state unknown and report F29 when it is not known. Otherwise, it's reported incorrectly and it doesn't report, that the clinical situation. And CMS is announcing they are denying unspecified codes. It's kind of one of their movements, their changes they're making. After, the initial visit, it's understood, visit after visit, that becomes a red flag. Okay, now on to mood disorders. So depressive, bipolar, cyclothymic. Please specify which it is. We often see these words used interchangeably, and it's important to specify which in documentation to support the code you report. Please also specify if this is a single or recurrent episode, if the episode is mild, moderate, or severe, and if it is partial or full remission. So please remember the documentation must support the code, and both documentation and code should represent that clinical picture. And I know I sound like a broken record, but this clinical picture is the data that CMS needs to support patient care and treatment and understand, of course, what it will cost to care for the patient. And when we're talking about, specifics of these episodes, so a single episode doesn't always mean the first occurrence or only occurrence. There can be more when the patient doesn't meet the criteria for a recurrent episode. And recurrent means there are intervals of at least 2 months, 2 consecutive months between separate episodes. And full remission is no symptoms of the mood disorder for more than 2 months with or without treatment. That is, with or without treatment. And then partial remission is when full remission hasn't yet, been achieved. So partial remission is no symptoms of the mood disorder with or without treatment, before that 2-month time frame. Okay, for bipolar disorder, please remember to specify if it is bipolar 1 or bipolar 2. For bipolar 1, we need the specificity like we were just covering. There are a list of, specifics. So please do specify, is this episode, with or without psychotic features, mild, moderate, or severe. We need those specifics for bipolar 1. For bipolar 2, we have F31.8. And F31.89 is other bipolar disorder. And then F31.9, of course, for unspecified. Please be careful using unspecified so that you are reporting what is current. Okay, these are unspecified codes for depression and major depressive disorder. Please document and report the specificity known when you know. And again, these are codes that are red flags, when you report unspecified visit after visit. Okay, so we've been talking about being precise in your documentation and code reporting. And now I want to talk more about being concise with one diagnosis versus 2 or more diagnoses, like I've touched on. Bipolar disorder is a good example. Bipolar includes both depression and mania, like you know, and it is more concise and best represents the condition if you report one code, bipolar disorder, current episode, depressed, moderate, instead of 2 codes, one for bipolar disorder unspecified, and then another for, major depressive disorder, recurrent, moderate. And this is not only concise, but it is proper reporting, and it is an ICD-10 guideline. So it being a coding rule, CMS will deny the diagnosis when you report the 2 separate diagnoses. Okay, so this is a quick recap of being concise and, being clear, because these are common mistakes and something, that people that I have had remarked that, you had no idea that this was a coding requirement or, could be an issue when you're reporting on claims. So these are the 2 most important areas where we see the issue. When you're reporting psychosis, if it is related to an ongoing or current mental or behavioral health condition, please use the code for that condition that includes with psychosis, instead of reporting F29 separately. And then bipolar disorder, like we just, covered, please use the specific code to include with depression, mania, or mixed, or with psychotic features. Most commonly, like on that previous slide, we see bipolar and depression reported separately. Please use this specific combination code. This is proper coding and reporting. And again, CMS may deny one or both diagnoses exist. Okay, here we have more codes for mood disorders. Like you see listed, persistent, cyclothymic, dysthymic. And then you see below each one what might be in your documentation that would lead us to, for you to report that code, like, neurotic depression for dysthymic disorder. So when please do specify and report the specific code. Anxiety is another commonly reported as unspecified. So if the patient has generalized anxiety, please specify and report that. You can see here what other documentation would represent and support generalized anxiety, or F41.1. This is another concise code to report is if the diagnosis is anxiety depression. Now that is if the depression is mild or not persistent, or mixed anxiety and depressive disorder. Please specify that and report F41.8 instead of 2 codes, one for unspecified anxiety and another for unspecified depression. Again, this is something we see often, and the diagnosis could be denied. So it is appropriate to report the one concise diagnosis. For Alzheimer's, please specify if it's late or early onset. If you have a coder, the coder is not able to code or assume on, from the patient's current age. And also please note each encounter if there are changes in acuity, changes in treatment, or life changes. This supports your recommendations, and of course it supports continuity. Dementia needs specificity of cause. Is it vascular or, due to other diseases like Alzheimer's or Parkinson's? Please also specify and report if it's with or without behavioral changes. Codes were added in 2023 to specify if this is, if the episode, if it is mild, moderate, or severe, as well as with or without agitation, behavioral, psychotic, mood, or anxiety disturbances. So document and report these details to best represent the patient's cognitive state. And you see here the same note to include each encounter if there are changes in acuity, changes, to treatment or life changes, like, it's common, visit after visit in these diseases, changes happen frequently. Please also have in documentation for the encounter whether the encounter is face-to-face, via audio and video, or audio-only telemedicine. So when you're billing certain CPT codes, there is now modifier 93 to indicate this is a telemedicine service via audio only. And there are specific CPT codes that modifier 93 applies to. So please do have your updated ICD-10 and CPT books, to have these updates each year. And, they are on the CMS website. You can download from there as well. And ICD-10 and CPT does have ebooks. These are easy, and some, prefer ebooks over the hard copy. Okay, like I have said, for many conditions, accurate diagnosis coding not only tells what the condition is, but also explains what is going on with or due to that condition. So document and report specificity, like manic, depressed, or mixed, and acuity, like with or without psychotic features, to best represent the true picture of the patient's health and status, which in turn supports care and treatment of your patient and improves continuity of care. And I hope I have, represented here how this is done through the diagnosis codes you're reporting on your claims, giving CMS that accurate data. Also, if you report a specific diagnosis on your claims, please be sure that specificity is documented in your record. This happens with certain EMRs, especially. There's a drop down. You can choose a diagnosis, and there's a drop down for specificity. So, this is wonderful. Here you're reporting the specificity. Just be sure the documentation supports that. Okay, it has been some time now, but in 2023, big changes were made to CPT codes, your E&M levels, choosing your E&M levels. This is all part of moving away from fee-for-service to value-based care, and this does include behavioral health documentation. For many years, behavioral health documentation and billing was all its own specialty. There were no real rigid guidelines regarding your documentation. However, now medical decision-making and documentation supporting time are the main factors when you're deciding your E&M level. So document the importance of what you're looking at and what you're looking for to support the complexity of the visit. Please remember to document time spent, the amount of time reviewing and counseling. And we talked earlier about documenting, the complete clinical picture in your assessment, including all chronic conditions that contribute to what you are evaluating in the current encounter, as well as all, chronic conditions that are affecting treatment. Remember, these factor into your medical decision-making and time spent. Okay, documentation and code reporting, like I've been talking about, reporting the true clinical picture, it does benefit you. Again, there's support for your medical decision-making, time spent. It improves authorization approvals. It reduces denials, and it can reduce audit failures. It can even mean, reduce the need for an audit. It can also mean less medical records requests from us because we're not needing to search diagnoses in your documentation, to validate a diagnosis. We run reports to be compliant with CMS, and those reports can identify red flags, and red flags to CMS can mean an audit. They run their own reports. They see red flags as well. But, when we're aware of these, when we see these, red flags or see or have common questions. We want to educate you, which is the reason for, my being here today, the reason for the webinars. So I hope I represented the necessity of reporting the true clinical picture of the patient, how this is done through diagnosis codes. You report on your claims, giving CMS the accurate data needed. And here are some of the basic guidelines, ICD-10 basic guidelines for diagnosis code reporting that we've been covering. So I'm not going to read through this. This is just how they're listed. And this is straight from the book. But this last one, this last bullet, I haven't touched on yet, a borderline diagnosis. So borderline diagnoses are coded as confirmed unless there is a specific code for borderline, like borderline personality disorder. We have a specific code for that. So when there's not a specific code and you state in your documentation borderline, then we would understand you to report the code for the active condition. Okay, and you as healthcare providers, you are required to document and report the correct, precise diagnosis to CMS. Arkansas Blue Cross is required to report to CMS the correct, precise diagnosis. Therefore, we do need your records to review at times. When we see the red flag, sometimes we want to look at something. We are not using records to deny your claims, and we will not ask for your confidential psychotherapy notes. Saying this, we do not review every diagnosis before it goes to CMS. But, none of us want to be faced with an ugly audit. We do not, I'm sure you do not. And when we at Blue Cross, when we see a trend or we can show you issues that we run into, then, we want to help you get it right. And many times, you as a provider, you're just unaware of, the current guidelines, what has been updated. You're unaware maybe of the big differences that subtle changes can make. You may be unaware of issues like we went over, stating history of a condition. Like I've said, I've heard that statement for many, many years. It's just common to say these things. However, understanding the guidelines, understanding, CMS, how CMS uses diagnosis codes to understand the true clinical condition of the patient, to understand treatment, that you are providing and recommend for your patient. Also, for CMS to be able to predict the cost of that patient. Okay, so if you do not have a query policy, it is important to set one up. This is good for outpatient. It's especially good for inpatient. Each practice should have a documentation policy as well as a query policy. And here are some templates that you can add to documentation to help make it easy for you. Some resources here. I'm happy to share that with you. Having an updated policy and procedure is critical. If you are ever audited, this could save or break you. So your policy and procedure, including your compliance plan, will be, the first things that you're asked to provide in an audit. And here are some things that should be present, and you can log on to the OIG's website and they'll give you specifics there too. Okay, these are the resources for what we've been covering today. So do you have any questions? Are there questions in the chat, Dr. Gibson? I haven't been.
Not any specific ones in our chat. Someone did text me a really, really good question or comment. I see Cindy. Yes, we will be sharing the presentation on the ABIN website. The link is in the chat and it'll have the PowerPoint. Interesting question from someone. This is extremely useful information, but with all the focus on payment, are insurance companies also looking at payment for quality? And that we know just because of what someone documents in the chart doesn't ensure they are providing good quality care. And as a psychiatrist, but also working at Blue Cross, I can assure you that we all want quality care. The challenge is, how do you quantify that and document it? I welcome anyone to help us figure that out. But the first step, and unfortunately, the physical and medical providers are doing better than those of us who are in the mental health world at really getting their documentation clear. And that includes the diagnoses and all the things that Kim has gone over. So getting the documentation of what the diagnosis is, and then us being able to follow patients that you're treating ongoing, and then to be able to measure, well, how do we know people are getting better and are they getting evidence-based treatment? And so this documentation is really a lot of the basics of us being able to communicate what care we're providing and everybody being on the same page, using the CMS guidelines, the codes and all for ICD-10 and CPT and all that. Kim, I don't know if you have a comment on that from this or even from your risk adjustment.
Well, I guess, some providers may be able to fake it, so to speak. But, it will come down, when you're reporting the data, when you're reporting, trying to convey as best you can your quality care, that will show through. And eventually, if there are inconsistencies, there's going to be a need to request, to review your documentation. So, it will be supported. And the more data the more data that CMS receives, the more they're understanding, they're understanding how conditions work with each other, how those chronic conditions are affecting your behavioral health condition. It is much more appreciated that there's a lot more for you to consider, as a provider. And it is, before you were only reporting, oh, I'm not reporting a diagnosis for something someone else is treating. But, it's really different now. You're trying to paint that complete clinical picture, and everything that you're trying to convey, everything that you are considering in your care and treatment. But, if there's a lot of questions, the documentation will be requested as well. And we may be seeing a little more of that as we go. But I do understand and appreciate that CMS is using this data to try to learn and try to understand, social determinants of health. Those factor in as well. And, trying to understand how all of this factors into the patient's, mental and behavioral health condition. That's important data.
I know when I was actually having to document for myself, we often, as mental health providers, didn't want to put down a medical diagnosis. Like if I'm seeing someone with bipolar, they also have diabetes and may have cardiovascular disease, hypertension. What comments can you tell us, Kim, about what we should be doing as mental health clinicians in terms of putting medical diagnoses in our charts?
Well, having the, past medical family social history, those chronic conditions, as well as social determinants of health, having those listed, you are explaining that is, affecting this condition. It does, kind of like I touched on before, and I hope I'm answering your question. It By mentioning it, you are explaining, by reporting it, you are explaining that due to these two, conditions coexisting, changes to, treatment now need to be made. And it is understood, well, and as CMS gets the, more and more data on that, it supports maybe specific medications that you now need to prescribe, a new medication that, hasn't been maybe previously approved or something. When these two conditions are being reported together, then it supports, the need for, a different medication, different treatment.
Very well said. And I can keep saying more because I have another comment, but I definitely want, if anyone else wants to come off mute to say anything or to put a question in the chat, we really welcome that.
And I see a question here. Will I be sharing the presentation slides? I do not mind personally emailing them to you. Send me an email and I'll forward it immediately to you. I'm not sure how you're going to post that on the
Jenny,
on your
Jenny,
website,
can
but
you
I'm
make a
happy to share it
comment?
myself as well.
Yeah.
What?
Jenny, can you make a comment about how the ABIN will have things shared on the website as well?
Sure. Yes, we will be posting the video and the slides. Thank you for sharing those, Kim. We will upload those as probably a PDF right to the website, and I'll include the webinar library link here in the comments.
And Jenny, I can forward my PDF to you if I have not already.
Okay, thank you. If you would.
Sure.
I hope to get that done today. It may be tomorrow, but it'll be by the end of the week for sure.
And if anyone here has a question, a specific question that comes up, please feel free to email me. I'll do my best to answer it. If I cannot answer it, I will try. I'll do some research and find someone that knows better than I and try to help you as best I can.
Thanks for that, Kim. And I put some links in the chat for other resources related to coding and billing for integrated behavioral health, as well as with Arkansas Blue Cross Blue Shield. And I was just going to make one or other comment on what you were saying about putting medical diagnoses on a mental health chart. And I think most of us know that if you have someone with bipolar disorder and they also have diabetes, and then you're trying to try different medications, potential side effects of metabolic syndrome and high blood sugars with some of the medications that we use to treat bipolar. Having that documentation shows that the patient you're treating is much more complicated than someone who does not have a medical disorder. And so what we're saying is that you need to get credit for that in terms of the risk scoring. And as we do move along and be able to reimburse people on a value-based care model, having the complexity of your patients documented and getting a pattern of doing that type of documentation is going to help you, because we know you're working hard trying to take good care of your patients and clients.
Exactly. That's much better said. That's what I was trying to say.
You said it. You said it. It's just having tried to do it myself, I know that documentation is hard. We're very bogged down, especially seeing mental health patients is very stressful. They're usually in crisis. And that's why we do need our clinic staff as well as our coders. I see we've gotten several of our coding and billing team on the webinar, and we do need, the clinicians need you and need you to understand all the work that they're trying to do. So let's just connect all the dots.
Well, we're all busy, even coders, you know, when we're busy in our working schedule, it's hard to keep up with updates. And sometimes that, you know, something can sneak in there that you just weren't aware of. And it's something you had been, you know, through habit reporting years, you know, for years. You know, it's hard to keep up with changes some of the time.
Yep. And in the past, we seem to think that if you write it down on your chart, you are responsible for it. And so that's why we as mental health clinicians didn't want to put any medical on our chart. So now things are different. It's that you are documenting that you are aware of it and you're keeping using that in the context of your mental health treatment as well. Well, we will still be on here for a few more minutes. If anyone else has any questions, feel free to hang on, ask them. Also, we've got our email addresses in the link, and feel free to contact us. You can see Kim's Blue Cross email is on the screen. Chris Curtis says, that is the difficulty I have getting medical diagnoses recorded. Yes. And we're not saying all this is easy. So let's work together and figure out some solutions. All right. Thank you very much.
Thank you so much, Kim and Dr. Gibson, and for everyone who attended. We will get this posted on our website and our webinar library today, hopefully. So thank you very much.
Thank you, Jenny.
Thank you, Jenny.
Thank you.
Thank you, everyone. Thank you for your time.